ورحمة الله وبركاته. معكم حمزة عبد الغني, College of Medicine, King Saud University. We are going to for the, I think, final session in the assessment. Very interesting topic, and very expert person in that topic, assessment for learning. So I have a great pleasure to introduce to you Dr. Daylan William. He's the Emerite Professor of Education Assessment at University College of London. He started his academic activity as a teacher of math and physics at a private school. And from there, he started moving from different places to improve mainly the assessment. So in 1984, Chelsea College of University of London, he was there as again in education. In 1996 to 2003, he acted as a dean of School of Education and assistant principals. In 2003, he moved to USA as a senior research director at the Education Testing Center. Again, in 2006 to 2010, he was a deputy director for Institute of Education of University of London. Now, since 15 years, his work is focused on the assessment for supporting learning. That's what we call it, the formative assessment. So now his whole working is with the expert in all over the world. He's working that how we can move from assessment of learning to assessment for learning and to promote the formative assessment previously and now is the assessment for. So give a big hand for Professor William to start his topic.
Thank you. And so my talk is going to be somewhat more general than that of Professor Fuller. I'm going to try to give you a framework for thinking about change. So I am going to talk about assessment for learning, but I'm also going to talk about curriculum and pedagogy, because I think it's very hard to separate pedagogy from assessment and to separate pedagogy from curriculum. So I'm just going to share my screen. And the PowerPoint slides will be available later on. So the outline of the talk, I want to talk about two overriding issues that should govern our thinking about any change in medical education or indeed in any other kind of change. We need to understand why things are as they are, and we need to understand that improving our system involves making trade-offs. There is no perfect assessment system for medical education or for anywhere else. What we have are trade-offs, and so we can plan these trade-offs. We can say, yes, we're going to have more of this, but less of this. Or we can just take decisions without understanding the trade-offs, and we just end up somewhere that we don't really plan. They emerge as unintended consequences of other decisions. I want to spend a little time talking about what educational research can and cannot do to inform medical education in particular. And I want to suggest there are three best bets for improving medical education, focusing on curriculum, focusing on pedagogy, and focusing on assessment. So let me turn to a framework for thinking about change. There's a wonderful short story by G.K. Chesterton. And the idea is that somebody sees a fence in a field and they can't see the purpose of it. And they say, I don't see what that fence is good for. Let's take it down. Let's get rid of it. And Chesterton says, in the matter of reforming things as distinct from deforming them, there is one plain and simple principle, a principle which will probably be called a paradox. There exists in such a case a certain institution or law, let us say for the sake of simplicity, a fence or gate erected across a road. The more modern type of reformer goes gaily up to it and says, I don't see the use of this, let us clear it away. To which the more intelligent type of reformer will do well to answer, if you don't see the use of it, I certainly won't let you clear it away. Go away and think. Then when you can come back and tell me that you do see the use of it, I may allow you to destroy it. And I think that's a really important framework for thinking about change in medical education. There are things that we do, we say, well, I don't see the point of this. Well, in that case, you probably haven't understood how the system works, and changing it might actually lead to these so-called unintended consequences. The big idea here is there are no perfect solutions, there are only trade-offs. And when people come up with new ideas, say for assessment in medical education, they're usually very clear about the things that the old system did badly and how their system will do something much better. They're usually silent about the things that the old approach did well and the new proposal did less well. So we could take, for example, a movement from multiple choice testing towards OSCEs, objective structured clinical examinations. And people say, well, the OSCEs are much more authentic. That's true. But what are the trade-offs? What's the downside? And so if you're not clear about what is going to be worse and what is going to be better, then you're not really in a position to make any smart choices about change. So I suggest that whenever somebody comes up with a new idea for medical education, or indeed anywhere else, they should be asked two questions. What would be better if we make these changes? And what would be worse if we make these changes? And if a person comes back and says to that second question, nothing, then I think they need to go back and think again. The point is, there'll always be trade-offs. The question is, are they explicit and planned, or do they just emerge as unintended consequences of decisions taken elsewhere? The other thing that I've become really convinced of in my work in education over the last 40 years is that the most important concept in education, particularly in improvement, is opportunity cost. Every hour we have our students doing one thing is an hour they don't have to do something else. Every hour that our lecturers spend doing one thing is an hour they don't have to spend on something else. And so that's why I think we need to be very careful about where we focus our efforts. And I think in education, it's really difficult because it's a very messy thing to research. So as Robin Hogarth points out, learning from practice to improve practice involves making inferences, drawing conclusions. And he points out there are two settings involved. The information is acquired in one setting and is applied in a different setting. So what's important for the learning organization is what's the match between these two settings? The setting where you learn about what works and the setting where you apply your ideas about how to improve things. And I would say that education in general is much more complicated than people suggest. So Hogarth suggests there are two kinds of learning environments. A kind learning environment is one in which there's a close match between the two settings. So chess is a kind learning environment. What you learn in one setting is probably applicable in another chess game. Tennis is a kind learning environment. What you learn in one setting is probably applicable to the other games you will play. A wicked learning environment is one in which there's a poor informational match. In other words, what you learn in one setting may be completely inapplicable or even counterproductive in a different setting. And my argument is teaching in medical education and elsewhere is a wicked learning environment. So for example, when teachers are teaching highly achieving students, they get higher ratings as teachers. Not because they're better as teachers, because they look better because their students are so smart. The hardest thing in education is that performance, how well people do in a learning task, is not learning. So every teacher has had the experience of explaining things to students, and the students seem to understand it, they can do it at the end of the session, and 2 weeks later, it's as if that session has never taken place. The point is that performance is not learning. Learning is a change in long-term capability. Performance is the performance in the learning task. And not only are they different, recent research from Robert Bjork, a psychologist at the University of California, Los Angeles, has suggested that they're inversely related. Unless students struggle somewhat, what he calls experiencing desirable difficulties, then their learning will be less permanent. There's some nice studies from the US Air Force Academy that shows that teachers who are more successful in the short term and get higher ratings from their students are actually less effective in the longer term. Students like teachers who make things easy, but making things easy often doesn't lead to good learning. When things work or don't work, without good theories, we might learn the wrong lessons. So there's a good example here in coronary bypass grafts. A study in Pennsylvania looked at the success rate according to how many procedures the surgeon did in a month. And if they did 20 or more per month, then the mortality rate was 2%. If they only did one a month, it was 3%. So a 50% high mortality rate if the surgeons didn't do this procedure very often. And people assumed this was a practice effect. But some subsequent analysis showed that it wasn't that at all. If somebody did 20 procedures every month in different hospitals, the mortality rate was 3%, the same as for people who only did it once a month. It was a team effect. So unless you realize that this might be a team effect rather than a practice effect, you will draw the wrong conclusions. Doctors need lots of practice. No, maybe they need to work with the same team. So without good theories, we will draw the wrong conclusions. And of course, we all know about things that work in some contexts, but not in others. So that's why people have suggested, well, we shouldn't look at one study, we should look at meta-analysis. And what I'm going to suggest here is that meta-analysis is a very good framework for research in medicine, but not a very good framework in medical education, because the contexts that are being aggregated are too similar. So the first is, how do you select all the studies? How can you be sure you've got all the studies? There are also problems with studies working in some contexts and not others, what researchers call aptitude in treatment interactions. A huge problem for meta-analysis is this file draw problem. It's much easier to get studies published if they're significant. One estimate in health education is that it's 12 times easier to get a paper published if the result is significant. And so a lot of the other studies don't get published, they are in the researcher's file drawer. And a recent analysis by Kvaven and her colleagues looked at psychological studies, and they looked at the effect sizes that were reported and the effect sizes that were found if you limited the analysis to the studies that were replicated in multi-site settings. And what they found was that the studies that were well done gave much smaller effect sizes. So the green squares here are the replication studies, the red squares are the published results. And the true effect is about 1/3 the size of the published effect in the meta-analyses, because the meta-analyses gave weight to badly designed studies and didn't include, and there weren't many replications. So in education, we make inappropriate comparisons. The point is, we might compare two different studies on cooperative learning, but unless you define cooperative learning, you don't know you're comparing like with like. Sometimes the intervention is of different intensity. So if we took a look at small group learning, you're talking about 8, you're talking about 4. We often have issues with less variable populations. So in medical education, because they are usually fairly high achieving students, we get a very narrow range of achievement, and therefore the effect size calculation gives you a much bigger effect size because the denominator of the effect size calculation is so small. But most importantly, and most challengingly, I think, for medical education, the outcome measures we use to measure the effectiveness of our interventions aren't standardized, and therefore some are much more sensitive to the effects of our teaching than others. The paradox here is that in education, effect sizes are justifiable only when they're unnecessary. So that's why meta-analysis works well in medicine. If we compare 5-year survival rates, if we compare time to discharge from hospital, then we're using the same outcome measure in different studies. But if we have a medical assessment, then we don't know that the assessment is measuring the same thing in different studies. So some problems are avoidable. There are ways of overcoming these things, and some problems are unavoidable. The challenge is, for me, the reason that meta-analysis is really hard to do well in medical education, most meta-analyses don't avoid the avoidable problems and don't discuss the unavoidable problems. Meta-analysis is, in my view, currently an unsound basis for making policy in education. So what is the role of research? Well, the first thing to recognize is that evidence-based is a continuum, not a category. You know, people say we want evidence-based approaches, but that's not a thing, it's a degree. And so research can tell us where efforts are unlikely to improve education. For a while, people thought that teaching students in their preferred learning style might be helpful. We now know that's unlikely to be the case. It can tell us when things will work and when they don't. It can tell us how much improvement we'll get, and it can tell us about the costs. And that's the important trade-off, costs versus benefits. So the questions we should ask of research is, does it solve a problem we have? Because if you've already solved the problem, it's not going to help. How much does it cost? In out-of-pocket costs, sure, but more important in terms of educator time, how much extra achievement will we get? Not in effect sizes, but in extra months of learning per year. Purists say, well, it's very difficult to get those estimates. Yes, it is, but it's the only metric that matters, because any improvement in medical education manifests itself as students learning more in the same amount of time, or learning the same amount in shorter time. So how many extra months of learning per year, and then will it work here? Can we implement it here, and do we know what to do? And when we actually ask those questions, when we become critical consumers of education research, it's clear there are three best bets: improving curriculum, improving pedagogy, and thinking carefully about assessment. So why is curriculum important? Well, there's a famous TV show in England called Countdown, and in one of the segments of the show, they ask people to construct a given number, in this case 127, by combining different numbers using the rules of arithmetic: addition, subtraction, multiplication, division. And the question is, can you make 127 using those numbers? Even if you haven't solved it yet, I'm pretty sure that for most of you, the fact that 25 times 4 was equal to 100 just leapt into your brain. It just came there without you thinking about it. And that's why it's very dangerous to say people don't need to know the multiplication facts, because experts always see things because the environment triggers their expertise. So the model of human memory that actually explains this very nicely is we have the environment triggering things into short-term memory, and long-term memory also triggers those things. And the important point is that short-term memory is limited in capacity and in duration. Long-term memory is pretty close to limitless. We've never found the limits of human memory. There are some people with a condition called highly superior autobiographical memory. They can remember every single thing they've done on a particular date. And so, as far as we know, the human brain doesn't have any limits in terms of its capacity. The main purpose of medical education is to enhance the contents of long-term memory. I don't just mean memorization, but I mean the concepts, the way that things fit together, the connections between bits of knowledge, so that you can make those kinds of diagnostic leaps. And I think we have to remember this. It's not really about making people more skillful and better thinkers. It's giving them more to think with. This is, I think, brought home by John Sweller, Richard Clark, and Paul Kirshner. They describe learning as a change in long-term memory. If nothing has changed in long-term memory, nothing has been learned. And John Sweller points out, novices need to use thinking skills. Experts use knowledge. I think that's a really important point. Thinking skills are what happens when you don't have enough knowledge to solve this by recognizing it. So one of the kind of more pernicious myths we're hearing these days is knowledge isn't important, you can always Google it. Yes, but the point is you won't know what to Google, and you won't make those connections unless you have that long-term knowledge. We often think that learners should be involved in authentic tasks, and that's engaging. The challenge is that often those authentic tasks lead to students being successful without actually having any learning. People say we should be teaching skills, not content. I don't think there's a meaningful distinction between the two. As E.D. Hirsch says, skill is content, content is skill. And so I think the main purpose of the curriculum is to enhance the content of long-term memory. And so there's a couple of things here we need to be aware of. One is how to get things into long-term memory. John Sweller suggests that a powerful framework is to think of our brains in terms of their evolution. There are some things we're evolved to do, like speaking and listening. And we acquire these things naturally if we are exposed to a suitably rich environment. There are some things we are not evolved to do, reading and writing. If reading and writing were natural, we'd have figured out how to do them earlier than 5,000 years ago. So he suggests there are 5 biologically primary principles. I'm not going to go through all of them in detail. I want to highlight one of them here. The narrow limits of change, the bottleneck principle. It turns out that we don't really understand how things that we experience get transferred into long-term memory. It's quite a mysterious process. And that's why it is that students can be successful in a task that we give them to do. Their performance on the task is high quality, but they don't remember anything of it 2 weeks later. The fact is that not all of our experiences get through the bottleneck. And one of the things that's been shown recently by John Sweller and his colleagues is that the amount of cognitive capacity that you have for processing is crucial. So some things are just hard because they're complex. They involve processing things at the same time. Some things are hard because we make them harder than they need to be. Extraneous cognitive load. So for example, if we give students a diagram with text on one side and the diagram on the other side, then they have to split their attention between the two, and that makes it harder. For people with lots of cognitive capacity, with high working memories, it doesn't affect their learning. For people with less working memory, it makes it much more difficult and they end up learning less. So extraneous cognitive load is reduced through good instructional design, not making things harder than they need to be, but then making things harder in a good way by careful instructional sequencing and making sure that as much as possible that they need to use to solve this problem is already in long-term memory. So for medical education, particular strategies, we decrease extrinsic load. We give them worked examples and ask them to complete problems. So we actually show them one worked example, and then we actually show them a similar example, but we leave out the last step and then the last 2 steps. Reduce split attention effects, where they have to split attention, and also reduce redundancy, where you actually talk and write at the same time, because that seems to make processing more difficult for some people. And of course, using multiple channels, making things visually present, as well as using auditory channels at the same time, again, in a smart way. For medical education in particular, progress from low to high fidelity cases. So start from simple cases and let people build up those ideas, progress from simple to complex, and then optimize germane load, the relevant load. So we start off with simple cases, and then we will make them much more complicated. We chop them up and change them about, and we increase the variability of the cases. And these are the suggestions from researchers in medical education about how to make instruction more effective in medical education. The other thing, of course, is the expertise reversal effect. Worked examples are more effective than problem solving for novices. The reverse is true for experts. So as our students get more expert, we should move away from worked examples to challenging problems. But, and this I think is the most counterintuitive feature of cognitive load theory, the best way to get good at solving problems in medical education is not to have students solve problems, at least not to begin with. And that, I think, is quite a counterintuitive solution. Having students solve real problems is engaging, it's exciting, it feels authentic, but it doesn't seem to lead to the kind of learning that we want, especially in students with less working memory. The second strategy for pedagogy is making our teaching more responsive to our students' needs and more engaging. And so that's where the formative assessment part comes in. We think about where the learner is, where they're going, and how to get there. The role of the teacher, the peer, and the learner gives us 5 strategies. So first of all, we clarify, share, and make sure that our students understand the learning intentions. We elicit evidence of learning, not just questioning, all the things that we can do to help our students, to help us learn what our students are thinking, observing, noticing, providing feedback that moves learners forward. I think this is really very important. In medical education and elsewhere, we tend to assume that the purpose of feedback is to help the student improve their work. It's not. The purpose of feedback is to improve the learner. The purpose of feedback is to help that student do a better job on a similar challenge at some point in the future. And too often we think of feedback as looking backwards, telling the student how their work could have been better. In fact, feedback should look forwards. And then we have to use peer assessment to help each other improve their learning. And finally, self-assessment, students as owners of their own learning. And in many ways, this is the most important strategy of all. I'm often asked to observe people teaching. And when I observe somebody teaching a lecture or a session, I can guarantee that the first question they will ask me is, how did I do? To which I say, how do you think you did? I'm not doing that to avoid the question. I'm doing that because if that teacher can give me a good answer, my work here is done. That person knows what they need to do to become more effective. That person is becoming, in the psychological jargon, a self-regulating learner. I think this is the really important point. The purpose of feedback is actually to promote more effective self-assessment. Good feedback works towards its own redundancy. Good feedback equips learners with the skills they need to manage their own learning more effectively. And if we keep those things in mind, I think we will actually make better decisions. So the number to think about this is the second and the third strategies are responsive teaching. The second and third rows are the learner's role. The point I want to stress is that formative assessment, assessment for learning, doesn't tell you what to teach. It doesn't tell you what your students should be learning. It doesn't tell you what happens when learning takes place. It's just a recognition of the fact that learning is complex and our students often don't learn what we teach. As David Ausubel said 50 years ago, good teaching starts where the learners are. Ascertain this and teach accordingly. But because different students will make different sense of what we say, we need to use assessment to make our teaching more effective. Assessment is the bridge between teaching and learning. It is only through assessing that we can figure out whether what we just did has actually had the intended effect. So before you can even begin to use formative assessment, you have to be clear about what it is that you want your students to get better at. I take no view about what medical education should seek to achieve. This is a framework for helping people once they're clear about what they wanted to achieve. So some good ideas for feedback. A reminder, the purpose of feedback is to improve the student, not the work. The only thing that matters with feedback is what students do with it. A lot of people ask, should feedback be immediate or should it be delayed? Should it be specific or should it be generic? Should it be constructive or should it be critical? It doesn't matter. Those things have very small effects compared to whether the students use the feedback. So now there's been a lot of interest in focusing not on getting the feedback right, but getting the relationship between the teacher and the student right, so the students actually welcome feedback. And that's where growth mindset comes in. If you have a fixed mindset, then feedback is potentially unwelcome because it might show you're not as smart as you thought you were. If you have a growth mindset, then you're always going to be hungry for feedback because you know you can get better and the feedback will help you channel your efforts more effectively. And so I think one of the things we've learned over the last 10 years or so is that attention paid to helping students get ready to receive feedback is usually better spent than worrying too much about getting the feedback exactly right. My criterion is this: if you're getting more of what you want from your students, it's good feedback. If you're getting less of what you want from your students, it's bad feedback. As a general idea here, I think it's a good idea to keep in mind this idea that feedback should be more work for the recipient than the donor. Feedback should cause work for the learners to take their own learning forward. As I said earlier, feedback should work towards its own redundancy. Then in terms of pedagogy, and this actually overlaps into curriculum, how to strengthen long-term memory? Well, in a rather interesting study, some undergraduate students attended a 45-minute lecture on meteorology, 4 sections. They were tested on material, half low-order questions, half high-order questions. Students then reviewed half the material. That would enable the researchers to determine the effectiveness of the review. Half did so after 1 day, half after 8 days. They were all tested on everything after 35 days. Now, obviously, you won't be surprised the students did better on the low order material than the high order material. They did better on the stuff they reviewed than the stuff they didn't review. What is interesting is what happened according to the review interval. When the material was reviewed after 1 day, they did as shown in that chart. If they reviewed the material 8 days later, they did better. In other words, reviewing the material 8 days after the initial lecture had a bigger long-term effect than the reviewing the material 1 day later. Why? It's because of what we're learning about how our memories work. So as Robert Bjork says, your memory is not a hard disk. So we think of our memories as hard disks. We store things there and we retrieve them. Retrieving something from a hard disk has no impact on what's on the hard disk, but your memory is not like that. Any item in your memory has two characteristics. The first is how well it was learned, how well it is connected to other things in your memory, and that can only go up. Retrieval strength is how easy it is to retrieve at any particular time, and that goes up and down. Here's what's really important about memory. Storage strength, how well it's been learned, and retrieval strength, how easy it is to retrieve, can be increased by restudying an item or by retrieving it from memory, but retrieval has a greater impact than restudy. So successfully retrieving things from memory has a greater impact than restudy, and retrieval and restudy increase storage strength more when retrieval strength is low. And that's the reason that we saw those students doing so much better if they reviewed the material after 8 days rather than 1 day. Because they had begun to forget it, the same amount of time studying that material had a bigger effect if they restudied it after 8 days than after 1 day. And this has major implications for our curriculum in medical education. We need to be having a kind of little and often approach where students revisit stuff constantly, because that then produces a bigger increase in how well they've learned it, what is called storage strength in this model. That means we need distributed practice and practice testing. In other words, we should actually have the same thing repeated over many sessions, ideally quite a long way apart, and lots of practice testing. The idea is you retrieve things from memory, and that makes your memory stronger. Then finally, I just want to close with a few words about assessment. My framework, I think the one I prefer for assessment is to say that an assessment is simply a procedure for drawing conclusions. We give students things to do, we look at what they did, we draw conclusions. That's it. And so really, the important thing is, what conclusions are we allowed to draw? People often say, is this a valid assessment? Well, it will be valid for some conclusions and not others. So in the last 50 years, attention has shifted away from validity as being a property of an assessment and towards a property of conclusions. Once you see what the student has done, what are you allowed to conclude? Some conclusions are warranted, others are less so. That's why validity, I think, is a property of conclusions, not assessments. It makes no sense when somebody says, is this a valid assessment? Talk about validity as a property of assessments is what Gilbert Ryle calls a category error. It's giving something properties it cannot have. So there's a particular paradox in medical education, which is sometimes called the validity reliability paradox. So we try to make our assessments a bit more valid, moving away from multiple choice questions, for example. And so basically what we see is that attempts to improve validity by using more authentic assessments tend to reduce reliability. But the paradox is reliability is a prerequisite for validity. Because if you have unreliable data, you cannot possibly draw valid conclusions. So the reliability validity paradox is that attempts to increase reliability tend to reduce validity, while at the same time, reliability is a prerequisite. And so my resolution of this is to think about reliability. We increase reliability, it strengthens some conclusions and weakens others. So one way to think about this is stage lighting. we could use a floodlight to illuminate all the stage with some light, or we could use a spotlight to get a lot of information about one part of the stage, but then the rest of the stage is in relative darkness. So with multiple choice tests, we get a lot of information about a narrow part of the domain, but we don't get very much information about whether students can apply this in other settings. If we use broader assessments, then we get information about everything, but often the information is rather coarse-grained, and therefore we don't get a lot of strong conclusions about any particular aspect of the domain. The important point is the intensity of the lighting is the proxy for the amount of testing time. Obviously, we can make our assessments better by having more time testing, but there's better things to do with our time, like teaching our students. So the two main threats to valid interpretations that come from the literature is to suggest that there are two ways that assessments can be problematic. They can be too big or they can be too small in intuitive terms. So scores could depend on things they shouldn't depend on. So for example, if there's a very tight time limit, we might actually be giving an advantage to the quicker students. In other words, the score you get depends partly on how good you are at medical education and partly on how quick you are. If we have open-ended writing questions, then maybe handwriting matters. So basically, an assessment is too big when scores depend on things they shouldn't, like handwriting or speed of response. An assessment is too small when it depends on things they should. So another example is luck. So students have good and bad days, who actually marks the work, which particular task was set. Those are irrelevant to how good that person is going to be as a doctor, but they can often affect the performance. The assessment is too small. The problem there, of course, is we rely on multiple choice tests because other assessments are too difficult. So we assess only the things that are easy to assess. Paul Newton has suggested that we can think of these two things as signal contamination. The signal we get, the information we get, is contaminated with the relevant factors, and signal deficiency. If you want to look this up in the jargon books, then you can call them, they're called construct relevant variance and construct underrepresentation. Those are the technical terms here. The idea is we want the variation in student scores to depend on how good they are at medicine. That's the construct. If the scores vary on other grounds, then that's irrelevant to the construct, so it's called construct irrelevant variance. If the scores don't vary enough because you didn't assess important aspects of what you should be assessing, that's construct underrepresentation. So, some implications for assessment. There's no such thing as a valid assessment. Validity is a property of conclusions, not of assessments. Reliability is part of validity. Specifically, it's the random part of construct irrelevant variance. And there's no such thing as formative assessment. Formative and summative are descriptions of the conclusions that we draw from assessment information. So we can actually use the assessment outcomes summatively to say this person passes, this person fails, or we can use it formatively. That person needs to spend more time on this topic. The important point is summative and formative are not descriptions of the assessments themselves, they're descriptions of the conclusions we draw. They're descriptions of inferences. A couple more points and then I'll conclude. I want to point out how difficult this area is in terms of trade-offs. So here's a nice study from Brian Clauser and his colleagues. They chose 200 medical students who'd completed a performance assessment of patient management skills online. They then selected 100 of the students to use as a kind of benchmarking sample. They had 4 university professors then assess the 100 of these responses, and these assessors' responses were used to construct a scoring algorithm, and then this scoring algorithm was used to score the other 100 students. They then looked to see what causes the difference in scores. You see, what we want is the differences in the scores in an assessment of patient management skills should be entirely caused by differences in that student's ability to manage patients. That's the construct. So we want most of the variation in scores to be construct relevance. The difference between students in terms of their difference between different scores should be how good they are at patient management. That's not what they found. So some students did better than others, which we'd expect, because some doctors are better than others. The task they were given, whether they were actually got this task or that task, was actually a bigger factor. Which group of assessors assessed it had not much difference. Whether the particular task they got suited them, whether they were lucky in the task that they got, had a huge effect. And so here's the important takeaway. The person-task variance, as it's called, was larger than all the other sources of variance combined. In other words, how good you were at patient management, how hard the task you were given, who scored it, mattered less than whether you were lucky. And this is the challenge with performance assessment. Performance assessment is engaging, it feels authentic, it's popular with students, it feels real, but yet it has this massive hidden source of unreliability. Again, I'm not saying we shouldn't do these things, it's a trade-off. So, just a concluding framework for thinking about assessment. First of all, assessment systems should be distributed. We shouldn't just assess students at the end of the course, we should collect evidence over the whole of the course, so we get a distributed assessment system. But it also has to be synoptic. We can't just assume that if they did it in their first year, they still know it. So we actually have to make sure that we're accumulating knowledge. We have to assess all the important things, not just the things that are easy to assess. It has to be manageable, so that it doesn't drive lecturers crazy, and it has to be trusted. No assessment system can do all of these things, but by using these 5 principles as a way of thinking about the trade-offs we're making, we may be able to come up with ways of assessing our students in medical education that are, I think, better suited to the task. There will always be trade-offs. We can make them explicitly, or we can actually end up somewhere and with no idea of how we ended up there. So I'll stop there and hand back to see if there's any questions.